Good afternoon and welcome to HealthSystemCIO.com's All-Stars panel, the missing link in predictive healthcare, social determinants, a webinar tweet chat combo from HealthSystemCIO.com sponsored by LexisNexis Risk Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com and I will be your moderator today. We are having a simultaneous tweet chat hosted by Nancy Wilcox, our Director of Sales and Marketing. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view it in the Media Viewer panel on the right-hand side of your screen. We are also going to be using two other WebEx panels today, the Q&A panel, which you can use to submit your questions as they occur to you. Keep the default set to all panelists. We will address those later in the program, but you can send them in whenever you like. And you can download, the polling panel. We're also going to have a couple of polls for you to answer during our event today. So that will open automatically when we launch those polls. And you can download the deck using the URL on your screen. It's at the bottom of our slides and also being sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to have our featured panel discussion with Dr. Shafiq Robb, SVP and CIO at Rush University Medical Center, Cynthia Davis, Chief Health Information Officer at Methodist Healthcare, and Erin Benson, Director of Market Planning and Engagement at LexisNexis Risk Solutions. So without any further delay, let's get started. Dr. Robb, can you tell us a little bit about your organization and your role there?
My name is Shafiq. I'm the Senior Vice President and Chief Information Officer for Rush. Rush University Medical Center is a 3-hospital health system and 4 colleges, and it has a university. And we are located in downtown Chicago. And we are serving the people of Chicago and the Chicagoland. The main campus is about 664 bed. It's a tertiary care place known mostly for great care and quality care. And we are #1 in quality and especially good in orthopedics and neurology and cardiology. And we are happy to be invited in this conversation.
Excellent. Thank you very much. Cynthia? Cynthia, are you there? You might have yourself on mute.
Yes.
Okay.
Yes, I was on mute. My apologies.
No worries.
I am the Chief Health Information Officer here at Methodist Healthcare. We're a integrated delivery system serving the Mid-South. Majority of our care delivery processes in Memphis, Tennessee, also Olive Branch, Mississippi. We have 6 hospitals and we serve about 1.2 million lives across the Mid-South. We also have a large mix of both employed physicians, and we have a strong relationship with the University of Tennessee Health Science Center and have a very rich partnership around academic medicine, both in primary care and specialty services. We have one of the top 100 pediatric hospitals in the country, Le Bonheur Healthcare, and are known across the country and the world for certainly our care of children and then also our partnership around oncology as well.
Very good. Thank you, Cynthia. Erin?
Thanks, Anthony. Good afternoon, everyone. It's great to be here. I am Erin Benson. I'm the Director of Market Planning for LexisNexis Healthcare. I set and execute the product strategies related to our identity management and our social determinants of health solutions. So LexisNexis Healthcare is a data analytics provider. We leverage over 6 petabytes of data on providers, claims, patients, and members to help healthcare organizations address risk. So we help with challenges such as identity theft prevention, regulatory compliance, cost reduction, improved patient outcomes. But specific to our conversation today, we utilize that data to provide insights into social determinants of health that impact your patients and communities.
Excellent. Thank you, Erin. All right, Cynthia, let's start off with you. The term social determinants of health has been used a lot in the market lately. How is your organization defining what that means and where that data, where the relevant data comes from?
Certainly a great question, Anthony. And a little bit of history about Memphis, Tennessee and Methodist Le Bonheur. We serve a very large uninsured population. Actually, we are the largest provider to TennCare, which is our Medicaid payment program here in the state of Tennessee. And about 17% of the population under the age of 65 in our primary county are uninsured. We've had a long and rich partnership with a multitude of community organizations that serve the Memphis, Tennessee marketplace. Many of you will also remember, because there's a very key anniversary that is about to occur here in the Memphis area. It's around the 50th anniversary of the death of Martin Luther King. So both from a social aspect as well as a healthcare need aspect, we have a very high rate of cancer, heart disease, and diabetes in our community. So we've been on a journey, frankly, to make sure that we as a health system understand what are the biggest needs in our community, and then how do we best partner to address those needs in our service population. For us, it's been a journey even to begin to capture some of what we would call the social determinants of, I think we would all call the social determinants of healthcare. We'll all remember back when Meaningful Use started its journey in partnership with us, that we were being asked to collect even basic data elements around smoking and race. And not until the year 2010 did we here at Methodist Le Bonheur capture race in our registration process. So that's been, as we'll talk as we go on, certainly been, people have been concerned from both a ethical aspects, but also making sure that we're focusing really on delivering the right kind of care irregardless of race or payment source. So we've been on a journey on that front as well.
Very good. Erin, your thoughts around defining the term social determinants of health?
Yeah, I think it's very similar to Cynthia's. We use specifically the same definition as the World Health Organization, so they define it as the conditions in which people are born, grow, live, work, and age that impact their health. We've specifically looked at the types of ways that you can learn about social determinants about individuals, and there's lots of different ways out there. There's patient surveys, there's EHR data, there's general census data, but with our background and with the information that we collect, we've really focused on public records data because it's reliable, it can be standardized and consistently updated, and it can provide longitudinal as well as current information about individuals. So we've been collecting the public records information for over 40 years and have been able to utilize that to look for correlations to health outcomes like readmissions, healthcare costs, and ER visits. So we are really trying to provide that insight into individuals so that it's clearer for hospital systems and care providers to understand how they can start to impact those social determinants to improve care.
Very good. Dr. Rob, your thoughts around defining the term and where you're pulling the data from?
So first of all, both of my colleagues were eloquent. So I have only 4 short things to add. Number one is that the healthcare in the United States was bad a long time ago. It became better when we changed the drinking water, made it pure, and we introduced sewage cleaning. All of a sudden, a lot of infectious diseases like cholera and other waterborne diseases went away. So without that, our healthcare would not have improved. Second thing that we have to add is that CMS in its Innovation Center has about 20 questionnaires that helps you to understand the social determinants of health. Third point is that I came to Rush for this only reason I joined Rush, because Rush has a very unique, it's a university and a health system, and I'm the CIO over that, but the uniqueness that it has is that it cares about its community, and it actually is doing something that I have not seen anywhere else done. Rush, first of all, thinks that they cannot do it by themselves. They need to involve the community, and everybody has to take a lead. So they invited 122 companies together so that we all together try to figure out what to do about our communities and our health. Uniquely, where Rush is situated, on our west side of Rush, and as compared to the east side of Rush, there is a 10-year disparity of life expectancy. People who live on the west side of Rush die 10 years earlier than the people who live on the east side of Rush. We are approaching 4 things in it, and that's the last point. We are approaching, and I'll tell you what social determinant of health actually means in a minute. 4 things we are approaching. 1, we are approaching from the education point of view, both in colleges, schools, and the community that we are, for the social inequities and injustices that we are talking about. Second, we're looking at economic revival. Without businesses coming back in life and other things, things don't work. Third is security. That means safety and life. And lastly is health. The thing that completes social determinants of health is the following. In the United States, there has been talk about catastrophic care, talk about acute care, and then comes chronic care and as well as preventative care. For these cares, other than medicine, there are other things that actually happens in life, which means where people live, what people eat, and the other things like food, lodging, clothing, and other things, language, and their situation in life, that determines the medication adherence, that determines the readmission to the ER, that determines whether they will take the drug or not. So the choices of life. So those are the things that we are looking from. One component is the health component, in which we are trying to understand each our patient, that or the people we come into our community, whether they come to our hospital or not, whether they come to our clinic or not, if they live in the community, how we can reach, how we can understand, and how we can make the social aspect of healthcare, which is the most important part that will help change behavior as well as the adherence to healthy habits, which will overall change healthcare.
Let me ask you a follow-up question here. Is it safe to say that if we were not moving from fee-for-service to value-based care, we would not be able to focus on social determinants because it just wouldn't line up with the economics? Is it key that we're moving to value-based care, and that's why all of this can be embraced and it'll make sense financially for a health system?
Not really. Not really, because here's what it is. As you will ask questions and as my colleagues will answer, and I will tell you what we are doing here later on if you ask that question. But to answer your question directly is the following. We are treating a human being. And in the life of a human being, whether it's fee-for-service, whether it's fee-for-value, whatever the case may be, the most important thing is that as physicians, as healthcare industry, and as university, because we are all three, we are thinking that how to improve the overall health of our community. Community health means not only the individual, not only the person, but also overall situation that is costing money, but at the same time, how to make the nation with more abled people, and also to change the disparity and the injustice of social inequities that are causing bad things to happen.
Cynthia, do you agree with that? I mean, do you think maybe at least it's easier to get programs approved that are going to cost the health system money because they line up with the new economic model of healthcare?
I agree with Dr. Rob. I think, first of all, when you step back to think of the history of healthcare and medicine in this country, I mean, hospitals and physician practices were started purely in Memphis. We have a very rich history because of a yellow fever epidemic and the starting of Methodist healthcare from the church. But we were created, and I believe healthcare systems across this country were primarily created to serve the people in their community. And I think while the alignment for funding is certainly changing and the incentives have been changing, our first call to service is to take care of people and human beings. And I frankly think it's an exciting part, and what hopefully we will get to in this conversation, because we're finally able to access the data that allows us to see the health of a family and a patient across not just an acute care event, but what happens each and every day with them in their interactions with physicians, with pharmacy, with home care, and with other community health organizations.
All right, Erin, so let's say I'm wrong. So it's just a coincidence that, I mean, why are we talking about social determinants of health now as opposed to 15 years ago? Is it the technology and it's got nothing to do with the change in the economic reimbursements?
Yeah, it's an interesting question. It's interesting to hear Dr. Rob and Cynthia's responses, because I agree that's always been the base purpose, is to serve the community. And even today, if you ask hospital systems, their number one goal is to improve health outcomes, and that's how it should be. I do think, though, that the legislation changes make it easier to have the conversations and to target budget dollars towards community health initiatives and towards personalizing care for patients. So while I think it's always been the primary goal, I think things like macro and focusing on performance incentive payment programs that are tied to quality are starting to bring that conversation up more, even though for the physicians especially it's always been the primary driver. But I think having the legislation align with the mission does help a lot.
All right, very good. Thank you, Erin. All right, Dr. Rob, let's start with you on this one. What are your thoughts on how social determinants of health could or should be incorporated into a health system's overall population health and or case management plans? So is it really a component of a larger population health program?
So here's the thing, man. Anthony, I'm a rebel, so I mean, I don't believe what anybody says and what government says and people do. This doesn't work that way. The healthcare industry in our country was founded by faith-based organization and people who wanted to do charity. So, and that's how it happened. So to answer your question is the following. The health record is not complete without vaccination information, without eating habits, without social history. When we were taught medicine, subjective, objective assessment and plan, when we complete our history, in the history there is a family history, and then the place we have to write about social history. So in the social history, we have to write the socioeconomic status of the person and blah, 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 blah. So EHR has always been there. Doctors should have written the things, but now what's happening is that those things have impact, and also data is now available. Lastly, interoperability is also happening. So what it does, it gives you a complete picture of your patient. For example, if the patient speaks Spanish, or patient speaks Portuguese, or patient speaks Chinese, or English, all those languages, if you speak in the same language to the mother and explain the medication, it's easier. So to answer your question, that social determinants of health should not only be done by social worker in the ED. It should be totally part of the all inpatient and all outpatient, everywhere that social history, because it has an impact. Now we're understanding, and if you ask me the question later on, I'll tell you what we found out here by doing that. And we are finding out that if you know whether the person has a place to live, whether the person needs food first, then we'll take the medication, and whether the person has a job, or whether the person also has some other barriers of understanding. So to answer your question, absolutely should be incorporated into health systems, population health plan, case management plan, and every plan you have, because if you look at any doctor's EHR or any history, social history has always been part from the time I went to medical school.
Very good. Cynthia?
I think Dr. Rad brings up a wonderful point, and I was at a presentation recently. We're doing some work, some very creative grant-funded research work around diabetes care, where we are targeting African Americans, and we are giving certainly text messaging that's an education that's very specific to, first of all, their lab results, and then medication reminders. But to the point earlier, until things like food and housing and transportation and medication management and social support are addressed, it's really hard to intervene to improve the health of the community. I heard a researcher present recently, food is medicine for some of our patients, and not having an understanding across the entire care continuum, whether, we know patients don't always refill their medication prescriptions. Well, it's either, is it a funding? Is it I don't have transportation? Is it I'm not staying in the same house? The pharmacy has a former phone number to be able to reach me. Until all of those items are understood and then a plan of care, which is comprehensive across the continuum, can be implemented, we're really not going to start to see and move the needle in terms of caring for our populations. And I am, like Dr. Rad, a little bit of a rebel. I don't really care for the word population health because it sounds a little bit like a TAM. I really think we need to revert back to the terminology that we've long had in healthcare, in that we are caring for the life and the health of our communities. And I'll get off my soapbox now.
God bless you. Very nice.
You got an endorsement there from Dr. Rav. Erin, your thoughts?
No, I agree with everything that's being said. I mean, at the end of the day, if recommendations that are being made don't align with a person's physical environment, either because they live in an area where it's not safe to exercise outside, or they don't have access to, food resources, or, medications or treatments aren't affordable or conveniently located, or even if it's provided in a way that's hard for the patient to understand, whether that's a language barrier, or even an education barrier, it won't be effective at improving health. And that's why we're starting to see the studies that show that social determinants of health can impact upwards to 50% of overall health outcomes, whereas the medical care is only about 20%. And I think it's because of what Cynthia and Dr. Rob are saying. We need to introduce more on the social determinant side to really address the holistic person.
And it's not only the poor area or the rich area, does not matter. There are situations in high schools in the most affluent place where non-prescription drugs are available. And many things go wrong in the affluent areas too. So it's not like that, To understand a human being, you need to know the genomics. You need to understand the phenotyping. You also need to understand the electronic health record, but we also need to understand the social determinant of health, our spending habits, our environment where we are, because at the end of the day, we are all human beings. So to focus just on my genomics is not going to take care of me. My behavior that needs to change so I can become live longer, more healthier, to understand a human being. All these factors are necessary to get to that target number. And somebody very eloquently said that why are we doing it now? We are focusing on different things because we as human beings forget. When we used to have typhoid, we took an antibiotic, we got better. But now we are seeing that we are not getting better. Something else is not letting us get better. So that's why, and the data is available, and also the government is helping, and there's more focus, more talk about it.
Yeah, and I think you make a really good point that we shouldn't just assume that there's one fact about a person, like what neighborhood they live in, that determines their health. You talked about it could be in the high school. We actually at Lexis have a team of data scientists that have correlated different, basically, social determinants about individuals to different health outcomes. And one of the interesting ones that we found was the distance between you and your nearest relative has a big impact on your health. So your medication adherence is likely to drop if your nearest relative lives more than 25 miles away from you, whereas it's a lot higher if they live close. And it makes sense. You think about the support structure, but that's why you need to look at a lot of different information about an individual and not just, to your point, any one fact.
That's right.
And also, as you're using that information to plan interventions for care, making sure that you are, interestingly enough, get phone calls now for my husband's insurance plan, and I had an EKG 5 or 6 years ago. It was normal, but I get now a regular phone call asking if I'm at risk for cardiac disease. I don't have any lab values. I don't have, and the voice that calls me on the phone to ask me that information does not appear to be aligned with, my background. And so I think we also have to be very aware as we're using data that we're intervening appropriately and that we're also matching those interventions with people who speak the language and are, part of the social community at risk.
Very interesting. Cynthia, let me ask you, where does mental health fall? Is that more on the clinical side and that's going to be in the EHR, or is it, I don't know, it's probably not a social determinant of health, but obviously that's crucial information for dealing with someone who may have a physical condition but is not adhering to what they're being asked to do because of some issue with depression or who knows what. How does the mental health figure in all this?
We do, how we've tried to address this in our health system is we do screening assessments. And actually, I was just looking at some data before we joined the call about our trends over the last 2 years, whether in terms of the assessments that we're doing prior to or as a patient's being admitted and into the ED, are we planning the right interventions and are we seeing change? I think, certainly the balance of what's the pieces of information that are being asked and collected and how they're being retained, and then who has access to that information are all critical. But it is one of the social determinants that we do need to understand because it plays into the mix again in terms of family support, in terms of ability to access medications, food, housing, and all of the rest of the items that improve the health of our community.
Dr. Rob, yeah, go ahead, please.
Thank you for asking that question. And one of the things is there are tremendous abuse that happens, spousal abuse, parental abuse, children abuse, and also we often ignore the mental health aspect of healthcare. So thank you for asking that question. And like Cynthia said, people do screening, understand it, and at the same time, it complicates things if you don't have somebody who is a caregiver at home, or it complicates things if you don't have enough days left in your therapy. So that complicates things. And then when you're asking this question, it is crucial for people to understand that. Not only that, but sometimes you find a spectrum of different kinds of not only mental health, but other kinds of things that people don't talk about. And all of a sudden, you might have seen a very important segment on TV that Microsoft has started hiring people who have autism. They've started hiring people who have other things. We in our society still have to learn that different people bring different good things, and how we tap into that resource is a very important thing that the society still has to learn. And we have to learn, doctors have to learn, researchers have to learn, and social determinants of health gives us that aspect that a mother at home is taking care of a child, and one child has behavioral issue and the other child has some bipolar or some other thing. That complicates her life, how she goes to job, how she takes care of the kids, and when she comes back, and to have a support mechanism around that. That's why when Cynthia said that or I think somebody else
Erin?
said that, that they did a study, and in the studies people found out people who live the longest are the people who have at least one person they can call at any time, and that person will come to help them. That means you have a social network to support you. And if that social network is not there, then the community has to come and build that social network to support that individual and to support that family.
Yeah, Erin mentioned that. Erin, your thoughts on the role or the place of mental health information in our discussion?
Yeah, it's interesting. There's studies out there that will show that like 75 to 90% of primary care visits are due to effects of stress. And I know that's not specifically a mental health disorder, but you can definitely see how it plays in the mental health of all individuals. So there's a lot there that does tie to anything related to money and work and family. So I agree with everything that's been said.
Yeah, Anthony, I don't talk about things, man. I have a child and she's going to school, and now she has developed an eating disorder. So think about it. I mean, and we are going somewhere for therapy, and she's trying her best to understand stress can happen anywhere. So, and the funny and the extraordinary part is that she is on the honors list, and she's still maintaining her A's and all those things. So when you're asking about mental health and understanding those things, they are so key, even in the development of children, and especially girls, between the 9th grade, or they call it sophomore, or they call it freshman. From freshman to senior, what they have to go through for college and other places. That also puts an understanding of those social determinants.
Well, fascinating, and thank you for sharing that information. We appreciate it. All right, let's move on. Cynthia, let's go to you. Let's specifically talk about your health system and what you're doing and what you plan to be doing, and your vision for what you can achieve.
Certainly. I think let me just provide a little bit of a framework and context about some of our community partnerships, because I believe that's part of our secret sauce, certainly as we strive to improve and provide better care. For those of you that are from the South or from the Mid-South, you know that the church is an integral part of the social fabric in the community. And one of the things that historically we've done very well here at Methodist Lebanon Healthcare is that we have what's called a congregational health network. There are over 500 different member congregations in the Memphis Mid-South region that are part of the congregational health network. And so when patients and their families who come for services, whether they be in the hospital or in one of our other points of access for care delivery, come in, we do identify whether they are part of that congregational health network. If a patient and their family are admitted to the acute care facility, one of the questions we do ask is, are they, is it okay to contact your congregational health network person? And so there's follow-up, and it's an important point, particularly when we are talking about the social determinants of health around, do you have a support network? Do you have the one person you need to call? Do you have housing? Do you have support and a way for transportation? We also have very strong alignment and relationships with the federally health qualified clinics. We do outreach to underserved or medically underserved areas. We have, there's a wonderful organization called the Church Health Network, which has a very innovative, first of all, medical insurance plan, but also provides frontline community health service access. So we knit all of those together into a fabric of support care. We, like everyone else, are on a journey certainly to improve our care coordination and care management. Took a look several years ago to say, is the structure that we have providing us with the results we need? Are we leveraging our alignment with University of Tennessee Health Science Center and the University of Memphis? How do our patients in our community want to be engaged? Is it through the church? Is it through other areas, and are the processes consistent, and do we have the real-time information to, first of all, identify those are at risk either with medical comorbidities, but other either mental health, other social aspects, violence, support, and how are we leveraging our infrastructure for our medical homes and then care navigators. And then, really what are going to be the steps that are going to help us to work, and how are we going to measure the results of improving? Because we all know that if we look at the data either from the CDC or other, our states, there's usually a 2 to 3 year lag time. So how are we more quickly being able to understand, are we making a difference, and do we need to refocus and do we have the right, incentives? We've chosen a path, and we use, like all of you, are doing a little bit of different things in different venues. In our managed care, clinically integrated network alignment, we've historically had used some tools and risk management things through a company called Valence. We are migrating to another tool, but it will be it's leveraged by our care coordinators and care navigators, and we do focus because our top 2 items for care intervention in our community are oncology and certainly diabetes. We, on our acute care side, have been very innovative, and we use a Cerner footprint. We put some of those risk items into a real-time dashboard that is available to all of our clinicians and operators that shows things such as risk for medication adherence, risk for readmission, risk for not having social support. So part of the conversation that happens with a care coordination team, both when a patient and family are admitted, as well as when they're discharged, is to be able to leverage that information and create a plan of care that is going to help connect the dots, both on the acute care side, but then for the primary care network that supports patients and families. Are we perfect? No. We also, though, are doing a lot of work to understand very readily what are those things that are consistently being associated with higher or lower rates of admission, and then have written a number of rules and have a team of data scientists that work to also provide our care managers with a set of predictive information that looks at both socioeconomic status, which includes the social determinants that we spoke of, and then medical indices as well. Some of the interventions that we're using include phone calls, care navigators, real-time alerting to both ED physicians and our primary care team, health coaches that are based in what I refer to in the Congregational Health Network, and then our medical homes, and then in our post-acute venue, home visits as well. So it's a mixture. We're baking a cake, but those are the things, the targeted interventions that we have to support our community and beginning to see results.
Excellent. Thank you for that comprehensive answer. Dr. Rob, you want to give us the highlights of your health system?
I mean, Cynthia did a fabulous job, and what she said is phenomenal. I'm impressed, and we do the following things, the same thing that she's doing, but I can only add 2 or 3 things. First thing we have to be adding is that we have a closed loop system. Closed loop means we have our EHR, and we do the social determinant of health, and if there is a need of food, lodging, or clothing, then that goes from our system into a social software that is available in the market. There are 2, 3 of them. We use one of them, and they find the resources. There is a dictionary of resources in the community, 2,000, 3,000 resources, and when we match the food and the lodging and the clothing and the shelter to that information from that software comes back to our EHR, and from our EHR automatically goes into the phone of the recipient, whether it's a homeless person or whether it's a person living in a different area or affluent area, doesn't matter. If somebody has a need, it goes to that person's phone. When the person gets that alert, then the person goes and receives the food, lodging, and clothing if they need to be. And if they don't try to get that, then within an hour we send a nudge to them. And we use FHIR for the interoperability. That's one thing we are doing a little bit. I would like to mention. And second, what we are doing is that since we can't do this all by ourselves, so other hospitals and other health systems next to us, we have started connecting with them and their ED as well, so that we can also leverage our partners. Third, what we are doing is that we are also connecting with all the other FQHCs that are not part of us and other clinics that are not part of us, so the data can transfer at both places so that things can happen. On top of that, we are also starting a food pharmacy. That means when people get discharged from the hospital, they can avail that good food that they can take home so that they have food on that. So those are a couple of other ideas that we had, and Cynthia is 100% on point that churches do help, and congregations and people. It also gives them a place to go to. We're also using a machine that you might have seen that people use in the pharmacy to take their blood pressure. So we partner with a company and help them develop that protocol with our EHR, and we have distributed those machines at places, and we now have direct access to the patient and to the blood pressure at any time, height, weight, and BMI, and then we are doing the intervention accordingly. Other than that, I think Cynthia Davis has done a much better job than I would have done.
Well, sounds like you're both doing an excellent job. Erin, let me ask you, how do you see social determinant of health capabilities developing over the next several years? Where do you see this going?
That's a good question. So I think we are seeing a lot of what Cynthia and Dr. Rob were talking about, where they're connecting with community resources. We're also seeing a lot on the front end of doing predictive modeling by taking scores based on social determinants or attributes into different modeling to risk stratify the population so that resources can be allocated to the areas of greatest need first, or even just matched. So maybe those that are more likely to adhere to their medications get a certain type of treatment, and those that are less likely get more personalized care and more touch points. So I think we're going to see a continued use of it being used on the analytics side to really start to predict different patterns of behavior and then tailor the care management programs to the individual around some of that. We're also seeing where it can be used to help different care providers figure out what questions to ask of their patients. So if we see that they're likely to have a higher risk in certain areas, then they can dive more into those areas and focus on the things that are important to that individual. So I think over the next few years, we'll start to see more of that being used on the analytics side, and then a stronger connection between the hospitals and the communities in terms of being able to match those needs to specific resources and getting more to the individual level.
Excellent. All right, let's get a poll in here. You're going to see it open up on the right-hand side. It's a select all that apply poll. Which of the following types of data are you using to evaluate social determinants of health? Public records data, behavioral data, patient-provided survey data, or other. Again, check all that apply. So if you want to take a moment and answer that, we would appreciate it, and we will go back and look at that in a moment. Next question, Cynthia, let's go to you. What are the main challenges associated with incorporating social determinants of health into patient care?
I think, first of all, it's privacy and security, particularly when you come to behavioral health, and also making sure that you've got, there may be items in the record, and I'm specifically thinking around children, that a teenager may not want their parents or family members to understand. And I think also when you begin to collect and have more access to more data, when we think about the timeline for how much time we're really spending time with patients in each and every intervention. The more we necessarily gather, and doesn't always mean that we're going to have time and resources to connect. And so that's where I think the ideas of how we can leverage technology. I like the suggestion that Dr. Rabb talked about, bringing suggestions for how to connect with community health services into the workflow, into the phone of patients and families, not unlike what we're doing with bringing education and other interventional information to diabetics. I mean, we've got to figure out more efficient ways to be able to do this work because, frankly, as we all know, nobody's paying us anymore to have to help implement the broader mission of service.
Dr. Rob, main challenges.
I think, but other than what Cynthia Davis mentioned, I think still the interoperability and getting the complete information from the entire health system, different health systems together. That's one. Second is that we as naive people always think that we know better than the community, which is not true. The communities always know how to resolve their issues. So that that ignorance kills us. That's the second impediment. That means we are the impediment, not understanding our communities and not learning from them. Third is that what we are finding out is that in this world of social determinants, we just think that it's only ED. Instead of doing ED, it should be throughout the whole health system, which you had asked earlier. And lastly is that we just think that it's just because it's got food, lodging, and clothing we keep on talking about, and transportation, we just think that social determinant of health is only for certain neighborhoods. It's for everybody because it's part of your electronic health record, it's part of your, as I call it, I'm trying to create a new number for everybody, which includes all the factors that I had mentioned, which is proteomics, genomics, environmental. Social determinant of health is part of us that tells us that what else do we need to do. When we were growing up, our mothers asked us to clean the room, and she would repeatedly say the same thing. Well, if I didn't clean the room, then she knew that I would be a disorganized person, right? Well, but she never gave up on us. So similarly, if we understand what are other factors that will help us change our behavior or help us to become more productive in the society, but reversely, how to use that talent in the society. So to answer your question is that also community and societal understanding that social determinants of health have a role to play. We just think once you give the antibiotic, it's good to go. It's not like that. That is one component that we really need to understand. It took us so long as a nation to understand that we have to also give paternity leave, like you have maternity leave. So we are learning as a society. We're evolving to that, and I have great hope for that.
Excellent. All right, let's look at the poll results. And we see, you should be able to see that in front of you, the results. So we see for public records, 65% of people are including that. Behavioral data, only 18%. Patient-provided data, 71%, and other 6%. So Erin, obviously a big lag behind with the behavioral data. Your thoughts on that?
Yeah, I'm not terribly surprised by that because I think behavioral data is the hardest type to collect. It's a lot of times self-reported. That's why we've really focused on sort of the public records piece, and I see a lot of the patient-provided survey as well. I think, we were talking about challenges in interoperability and also the access to the data, and I think it's important to find sources that can be standardized and reliable and accessible over time so that you can load those into the systems and then create alerts and some of the different programs like the phone calls and text messaging and things like that based off of the data. And behavioral tends to be a little bit harder to track. But when you look at things like public records, there's connections there that you might not even think about. Like if you're a registered voter, you're actually less likely to be admitted to the hospital because of the fact that you're more engaged in your community. And so it's interesting connections like that you can make based on public records data. The behavioral data is an area that I suspect will be explored more over the coming years, and we're starting to look into that as well. But I think the easier access to data has been through the public records and through some of the patient survey information.
Very good. All right, we're going to do a little speed round of audience questions here and try and get those in before we go in a couple of minutes. Let me start with you, Cynthia. How do we shift investment from the clinical delivery model to investment in community-based social supports separate and apart from care delivery? In essence, flipping today's priority.
I think, first of all, we have to align the incentives. I think right now we're still in, for the most part across the country, in a mode of, we're trying to capture where we can fee for service, make sure that we maintain the margins. I think once the incentives continue to be aligned, I think the shift will happen naturally. And I think as partners to the business and clinical providers in our organization, I think we all in information technology play an important collaboration role in helping to define, measure, and report the value of these kind of interventions. I think that's how we can help the shift.
Very good. Dr. Rob, how is health coaching incorporated into your programs for coordinating improving wellness and compliance within the community, especially those identified with chronic conditions and multiple health problems?
So, Rush is a very sensitive and mature place. That's why I came here. And I'm working we have a senior vice president that is dedicated to social justice and social inequities and bringing healthcare to be right. So, Rush, we are serious. We're serious about this, so it goes from the top to the bottom. We have a whole program behind it. And not only that, we are talking to our communities, learning from them. At the same time, one of the things that we are talking about is diversity. We're talking about including people. So I'll give you one example, which might help a little bit. When I took the job here after 1 year, we also teach in the local community school. And we took 27 interns in IT, and we hired 5 of them. So they are now part of our IT team. So we are also hiring from within the community. So those kind of coachings and program, short answer, it has to be deliberate. And when you are deliberate about it, second short answer, we have to show that it saves money. Third answer, it makes money. So for example, if you can understand the biggest killer in the west side of Chicago is hypertension, not shooting. So if you take care of hypertension, you will not have CVA. If you save 1 CVA, you save close to $1.3 million a year. So there is a calculation to that. So those are the 3-4 ways of making a point across. We can be emotional about it, but being emotional only helps us because we the people who are singing to the choir. But in the real world, those 3 things, you have to be deliberate, you have to save money, you have to make money, and you have to improve health. And that's how we are deliberately changing people.
I love it. Excellent, excellent. Erin, last question. We're about out of time. What is your advice for those on the line today that are from health systems who are just dipping their toe into this, want to include social determinants in their approach to, I'm going to unfortunately use the term people don't like, but population health.
Okay.
And they're just getting started. Is there low-hanging fruit here? Is there a way to get started? What's your best advice to them as we end up today's webinar?
Yeah, that's a good question. We get that a lot. I think there's a lot of different things and ways that you can impact it. I mean, you've heard on this call, you can talk to church groups and you can work through schools and all, and there's a lot of different interventions. I would recommend just picking an area where you see the biggest challenge. Are you having too many readmissions? Are you having too many ER visits from different patients that you wouldn't normally expect to be there? And then picking that one area and focusing on that and starting to do either getting data from different sources and starting to look at how you can see where social determinants are impacting that one metric, and then start to implement different interventions based on that. And I think if you start in a small area and see how addressing social determinants can help, then you can start to see how it would expand to helping other quality metrics and eventually get to some of the community level programs that Cynthia and Dr. Rob have been talking about.
Excellent, excellent. Well, I want to thank everyone for attending. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could answer that, we'd appreciate it. And for those of you who have continuing education interest in today's event, attending our events gets you 1 CEU towards the CHIME CHCIO certification program. Let CHIME know you were here, and if you've asked us to let them know, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive recording of today's event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox. You can go to our website to see our robust upcoming schedule of events. So with that, I want to thank our panel, Dr. Shafiq Robb, Cynthia Davis, and Erin Benson. I want to very much thank LexisNexis Risk Solutions for making today's event possible, and I want to thank you, our attendees, for always stopping in. But with that, everybody have a wonderful day. Thank you.
Thank you.